the skin. The most important abnormalities in the skin relevant to general examination are pallor, yellowness, pigmentation, cyanosis, and cutaneous eruptions. The skin is not only an important organ with vital physiological functions, but it is also the flag with which we communicate with the outside world. Skin disease places a strain on sufferers out of proportion to the disturbances in function which the pathology produces. A lipid complex is frequent, and social and sexual contact may be shunned. It's therefore understandable that patients with psoriasis, a persistent and often lifelong condition, show an increased incidence of alcoholism and psychiatric disease. Certain skin conditions may indicate an internal disorder, for example, pigmentation and thickening of the skin in the axilla and flexures of the limbs, a rare condition termed acanthosis nigricans may be a marker of internal malignancy, especially carcinoma of the stomach. Another example is pyoderma gangrenosum. This rare skin lesion is a classic example of a skin condition associated with internal disease. The necrotic ulcers, most often on the legs, are usually associated with ulcerative colitis, and total protolectomy almost always results in rapid healing. Let's deal with history. So, skin problems which bring a patient to see the doctor can be grouped into two: localized blemishes and abnormalities, which, although minor, may loom very large in patients' mind, together with skin tumors, both malignant and benign. Secondly, more generalized eruptions, and also problems with skin appendages such as sweat glands, hair or nails, and sebaceous glands. Presenting complaints. Find out the patient's presenting complaint. Has he come to see the doctor because of the rash, or he has other symptoms as well? Is the condition speeding rapidly? Did he notice a skin lesion or somebody pointed it out to him? Next is duration. Try and get an accurate idea of the duration of the skin condition. Patients tend to underestimate the length of time such lesions have been present. For the nature of the lesion, what exactly did the patient notice first? Was it something visible that was noted by chance when the patient undressed? Did symptoms such as itching or soreness develop before there was anything visible? And what did the original lesion look like? Next, you deal with subsequent change. So what has happened to the lesions since they started? Have the original ones disappeared and been replaced by others, or has there been relentless spread? Do the lesions come in crops? Is there a pattern to their spread? Has the lesion got a centripetal or centrifugal distribution? From there, you go to associated symptoms. The presence of pain, weeping, bleeding, and above all, itching should be noted. If present, the periodicity of the itching and exacerbation and relieving factors must also be noted. Next is topical application. Ask what the patient has been applying to the skin. Patients often apply some topical preparations on the skin rash before seeking medical attention. So what one actually sees may be the result of self-medication or inappropriate therapy. The original condition may have long since undergone spontaneous resolution. For general history, ask about the patient's previous skin diseases. Ask about other illness, both past and present, and any medication that was given. Also, ask about the patient's occupation and hobbies, as these may be the source of the trouble. Also, ask any travels both within and outside the country. Examination of the skin. The whole skin, including the hair, nails, and accessible mucosa, should be fully exposed, preferably in natural light. The main aspects of examination are inspection and palpation. Pulse inspection must have the pride of place. Palpation is also important, not only to aid diagnosis, but also to reassure the patient that one does not fear their skin diseases. For inspection, check the distribution of lesions. So in order to carry out a proper examination of the skin, the patient should be fully undressed within the limits of decency. Note any hypopigmentation seen in fungal infection, in hyperpigmentation, or general redness as erythroderma. And what is the pattern of the lesion on the skin surface? Are they, for example, symmetrical or just affecting exposed areas? If so, does the distribution suggest photosensitivity or a reaction to external factors? Note the presence of contact dermatitis in the dorsum of the feet with wearing shoes or sandals made with allergic substance, or earrings or necklaces to which the patient is allergic. The distribution of the rash gives the game away. Examine the surface of the scalp for fungal infection, alopecia, and scarring. Look behind the ears and external auditory meatus. Also include an inspection of the mouth. Raise the arm and inspect the axilla. Look at the nails and nail folds for clubbing, pitting of the nails, and fungal infection of the nails. Look in between the fingers for the burrows of scabies. Look under the breast for intertrigo and fungal infection, and gaze into the depths of the umbilicus. Look at the feet and in between the toes for fungal infection, like athlete's foot. Finally, look at the genitalia and perineal area for skin lesions. Okay, let's go to morphology. So morphology, look closely at the lesions and determine their morphology. A macule is a lesion which can be seen easily but is impalpable. Example, a freckle. When a lesion can be felt as well as seen, it may be described as a papule, or if more extensive, a plaque, or if deeper, then a nodule. Dermal edema with no underlying epidermal change produces a wheal, as urticaria. That's an example. Fluid-filled blisters on the skin are arbitrarily divided on the basis of their size into smaller vesicles, medium blisters, and large bullae. Blistering is an important physical sign. A number of conditions always blister, such as pemphigus, others occasionally, so like erythema multiforme. Pustules contain debris, leukocytes, and microorganisms, as well as fluid, but do not automatically indicate infection. The pustules of psoriasis, for example, are sterile. When the epidermis is lost, an erosion is formed, and the consequent oozing of serous fluid. When this dries and produces crust. Erosion will heal without damage to the skin, but ulcers produced by penetration into the dermis will heal to give scarring. Scaling is the accumulation of keratin, either normal or abnormal, on the skin surface. It may be the only visible change, as in some ectiosis, or accompanied by inflammation, as in psoriasis. Shedding of the horny layer is termed desquamation and can be followed by an inflammatory disorder such as xanthema, drug reactions, or underlying cellulitis. For the outline, the margin of the individual lesion should be carefully examined. Some disorders give rise to lesions with a clear-cut division between the normal and abnormal skin, whereas in others, the abnormal blends into the normal. Generally, a convex border indicates the direction of spread, where multiple small lesions have coalesced to produce larger patches. The margin will appear scalloped. Lesion planus is characteristically limited by fine skin creases, producing polygonal lesions. If the skin in the center of a lesion returns to normal, as it spreads, an annular lesion is formed. This is typical of ringworm, but it is not pathognomonic. Linearity may imply either an underlying structural defect or a response to external factors applied to the skin in a linear fashion, such as occurs in Koebner phenomena. And this occurs most commonly in psoriasis and lichen planus. Okay, for color changes in dark skins may be difficult, as redness may not be so obvious. As a general rule, very bright red erythema indicates an active disorder, and as activity begins to decline, the lesions become paler, sometimes with the redness being replaced by post-inflammatory pigmentation. Next is texture. Is the surface of the skin scaling or not? If it is difficult to determine the removal of surface grease, using a little ether is very helpful. If scaling is present and makes it difficult to see the base of the lesion, a little oil can be applied to the surface. White scales are seen typically in the discoid lesions of psoriasis. Finally, palpation. Palpation should never be omitted. It can be a great relief to the patient to know that one is not afraid to touch their skin. Relatives and friends may keep a secret, and their sex lives may be non-existent, so the last thing they want is a medical advisor who confirms their untouchability. Palpation also conveys a lot of information. The skin may be thickened, in which case it should be possible to identify whether the epidermis, which is the thickened, lichenified, or the dermis. The lesion may spread much further than it is evident visually, or calcified or cystic, cooler or warmer than the surrounding skin, as in erythema nodosum, or atrophic with loss of dermal collagen. Note any tenderness. In erythema nodosum, the red nodules of the skin of the legs are painful. Causes of erythema nodosum include infections like streptococcus, tuberculosis, leprosy, deep mycosis, and cattle ringworm. Other causes are sarcoidosis, Crohn's disease, and ulcerative colitis. The rest are drugs like sulfonamides and malignancies, especially after radiotherapy. Erythema nodosum may be persistent and the cause is unknown. Crusts, when present, should be removed from the sample area so the underlying skin can be inspected. As crusts are not firmly adherent to the surface, the simplicity of removal will also help to distinguish them from keratin, which is an integral part of the lesion and can rarely be removed with ease. Any scale should be tested for silveriness, which is pathognomonic of psoriasis.